Visible now?
Sir.
Okay.
Yes, sir.
Visible, sir.
Okay. So, cardiac output monitoring is the volume of blood ejected by each ventricle per minute and is the product of stroke volume and heart rate. This is the basic physiology. And it can be manipulated by alteration in the heart rate or rhythm, preload, contractility, and afterload. These are the factors which alter the cardiac output. Earlier, the pulmonary artery catheter and PAC insertion was considered as the gold standard method. And these are all the various techniques used, as you rightly put: fixed principle, thermodilution, Doppler method, pulse contour. And it is a cardiac output monitor. What are the ideal features of that? It should be minimally or non-invasive, because once the pulmonary artery catheter was introduced, it was thought as a panacea for all cardiac ailments. But later on, when the complications of pulmonary artery catheter were occurring quite frequently, then they said we should avoid PAC as much as possible and go for mostly non-invasive method. And it should be able to continuously give that. In PAC, we have to repeatedly inject the cold saline and then measure the temperature, and it's a little more tedious thing. Whereas the modern cardiac monitors, once you connect them, they are able to give a continuous display of the cardiac output, and it should not be too expensive, and it should be reproducible, and it should be reliable in all physiological states like hypothermia or hyperthermia, or patient with peripheral vascular failure, and that should have a fast response time. So these are the minimal qualifications or needs for this, and they can be broadly classified into invasive, which is the first and foremost method introduced, like the insertion of a pulmonary arterial catheter. Then the second classification can be minimally invasive, like finding out the cardiac output from a peripheral insertion of a radial artery catheter, or a catheter into some other major vessel, arterial vessel, or an esophageal Doppler or a transesophageal echocardiography. Or it can be totally non-invasive, like what she described as the last method of partial rebreathing, thoracic impedance and bioreactance, and endotracheal cardiac output monitor, Doppler method, and photoelectric plethysmography. So the classification is invasive, minimally invasive, and non-invasive. Now the first classification, invasive method of cardiac output, is even as early as in 1970, the Swan-Ganz catheter was introduced. And what is the other name for Swan-Ganz catheter? Vidya?
Sir,
What is the other name for Swan-Ganz catheter? And who introduced Swan-Ganz catheter?
Swan.
Swan, one person, Ganz is another person. How did they get the idea about this catheter? What is technically, how will you describe the Swan-Ganz catheter? Well, pulmonary artery flotation catheter. Okay,
Yes.
so you just inflate the balloon and then allow it to float along the flow of the blood. So they were standing at a hillock and watching the yacht going on a lake. No, yacht na pai mara kappal in Tamil. No, so the cloth that is tied in the yacht was blowing in the direction of the air. That is, and the yacht was navigated in the direction. So they got the idea, why not we also introduce a catheter with a balloon which is floating and which can go and settle itself in a level where we want. So this is also called the pulmonary artery flotation catheter. So more than your insertion, it floats and goes easily into the area and gets locked into that position. Okay, so it has been associated with the various complications like pneumothorax, arrhythmia, infection, and all these things. So technical errors may lead to false readings. So slowly it was in what was thought of an ideal method of measuring the cardiac output has now lost its reputation and become a little more obsolete. and continuously it can measure, of course, the cardiac output. And there is intermittent heating of blood in the right heart by the filament, and the resultant signal is captured by the thermistor. The mechanism how it acts is given there. Now coming to the minimally invasive methods. Next method, apart from the totally invasive, is the LITCO, lithium dilution cardiac output monitoring system. It was introduced in 1993. It will also measure the stroke volume and its variation. So here what you do is you inject a bolus of lithium chloride into the arterial venous side. So you require a central venous catheter as well as an arterial cannulation, and you measure the arterial concentration across a disposable lithium sensitive sensor, and that is calculated based on the lithium dose in the area according to the concentration time of circulation. And this requires practical usage. It requires calibration every 8 hours during major hemodynamic changes. And of course, it is contraindicated in patients who are taking lithium, and its accuracy is affected by aortic regurgitation or patients in intra-aortic balloon pump or damped arterial line, post-aortic surgery, arrhythmia, and intra or extra cardiac shunts. So in this, in relation to PSC, found a good correlation with the PSC by Linton et al. So it has been considered quite useful, except for the contraindication that is shown here. The next is a pulse contour analysis based on the principle that the area under the systolic part of the arterial pressure waveform is supposed to reflect the stroke volume. So you can see in this picture, this area under the which is shown there, the ventricular ejection, and then this is the diastolic period that is shown here. This is the ventricular ejection. This is shown here in the red and blue color. So in this method, area is measured post diastole into ejection phase. Now, these are all the other things that are measured, like stroke volume variation and pulse pressure variation. And the next comes the PICO method, which is introduced by Pulsion Medical Systems. And this expansion is pulse-induced cardiac contour, cardiac output measurement. And in addition to thermodilution curve, it can be used to measure the intrathoracic blood volume, global end diastolic volume, extravascular lung volumes are also measured. And global end diastolic volume and intrathoracic blood volume are a measure of cardiac preload, and extravascular lung volume is a means of quantifying pulmonary edema. So these are the other advantages with the SICO systems. And the next minimally invasive is a flow track system, which is also need not have an external calibration. It is operator independent. That is the advantage of that. And it is based on the same principle of linear relationship between the pulse pressure and stroke volume. And the good arterial waveform quality is a prerequisite for accurate reading of cardiac output in this. And it's affected again in patients with arrhythmia and IABP, like your PICO system. And it has in patients with low SVR undergoing liver transplantation or in septicemia, it is not found to be as accurate as pulmonary artery catheter. So that is why pulmonary artery catheter is still considered as the gold standard, because it measures everything at the heart level itself. Now, these are some of the pictures for you to remember what are the things that is. This is Massimo Litco hemodynamic monitoring system, and it will provide the beat-to-beat advanced hemodynamic monitoring. You need an already existing arterial line and the blood transfers to monitor the hemodynamic parameters. Pulse cardiac output algorithm converts beat blood pressure into consistent parts, flow, resistance, scale to each patient's age, height, and weight. And it is proven reliable on patients even on vasoactive drugs. That is the advantage of LITCO. And this is the flow track with the sensor and the monitor. And this is the PICO technology. You can see you require a central venous catheter here, and then you require an arterial line either in the femoral or in the radial or any of the major arteries. You have to do. You have to connect both to get the correct accurate cardiac output. Then there is a pressure recording analytic method, PRAM, measures the area under arterial waveform. The major advantage is it not require external calibration, and internal calibration is done by morphology of the arterial waveform by the machine itself. And there is a next thing minimally invasive is the esophageal Doppler, which is where the probe is kept in the mid-thoracic level, measures the flow of the descending aorta. And of course, all of you know the Doppler principle, the sound wave, how it is receding, it gives the accuracy of the volume. And moreover, discrepancies in this flow may be seen in aortic coarctation, aneurysm, or cross-clap because it measures the flow in the aorta, and instruments like IABP and other things may interfere with that. Now, transesophageal echocardiography, same probe which can be used for Doppler can be used for this also. And all of you know, we have discussed about that earlier class. And it can be kept at various levels, pulmonary artery level, mitral or aortic well, and you can measure the esophageal aortic long axis view or deep gastric view, and then use that for measuring the cardiac output. Now, the last classification of non-invasive method is what is called the partial gas breathing method. It is a non-invasive method, and it uses the fixed principle for calculation of the presence of partial gas rebreathing as a method. So here cardiac output is calculated according to carbon dioxide product produced by the central venous carbon dioxide minus content of venous of carbon dioxide to arterial carbon dioxide. That is the formula that is used. So VO2 is oxygen consumption. Actually, it is the production. CaO2 and CvO2 is the arterial and venous content. So the diffusion rate of carbon dioxide is 22 times more rapid than oxygen. That is why it is used, and it is naturally produced in the body. So that is the advantage. So making use of that, major limitation is it requires a tracheal intubation and a fixed ventilator settings, so that you don't alter the value of carbon dioxide frequently by hyperventilation or hypoventilation. And then the next thing is the thoracic bioimpedance, which is used as a non-invasive method again. Electrodes are fixed in a number of patients, number of positions. I will show you the pictures there, which measures the stroke volume using the formula volume of electrically participating tissues based on gender, height, and weight multiplied by ventricular ejection time taken from RR interval, and then EPCA, ejection phase contractility index, which is indirectly proportional to total electrical bioimpedance. So major limitations like the interference with electrocautery, other proper electrode, you must put the electrodes in proper place, and results are no longer not encouraging in critically ill patients. Moreover, it has been considered as a trend analysis monitor rather than a diagnostic method. So this is the partial rebreathing of carbon dioxide. So you can see this is the patient circuit is here. In this picture it is more clear, and this is the continuity shown here. So the patient's endotracheal tube adapter with a humidifier, everything is here. So this impedance to breathing, that component is attached here between the endotracheal tube and the breathing circuit, and this is how the volume of carbon dioxide is measured, and then it is the calculation is done. Okay, so that is the third of measuring carbon dioxide. So you have to, it's a very little boring topic. You have to mug it up rather than trying to understand, because most of the monitors, I think you'll have, unless you go for as a cardiac anesthetist or a liver transplant anesthetist full time, the usage of these monitors in your day-to-day practice is going to be very negligible. So you have to just mug it up for exam sake and reproduce and get your pass. And once if you are interested in cardiac anesthesia and continue, then you may will be mastering this by using it again and again in your day-to-day practice. Okay. In fact, I have not seen many of them. I just read from the books and reproduced it for your sake. Right.